Okay, today we're going to finish up this chapter and um, beginning with air volumes. And if you'll look on page 748, you'll see more terms listed than I have listed here on various air volumes, but these are the ones that I want you to know for the test. At any time, there's a certain amount of air that can be in your lungs. Um, and so that's what these are talking about. On that table, it gives you amounts in cubic centimeters. Um, you don't have to know the amounts, but uh, but you do need to know the definitions for each of these, okay, which is also on that table. But what the tidal volume is just when you're not thinking about breathing and you're in a resting state, just the normal amount of air you take in with each breath is called your tidal volume. And on the average, it's about a half of a liter. Okay, is the tidal volume. It's a good bit. Your inspiratory reserve is how much you can inhale after inhaling a tidal volume. So just your normal inspiration and then how much more you can inhale. That's inspiratory reserve. Okay. Expiratory reserve is the opposite. It's how much you can exhale after exhaling the tidal volume. So let's pretend like here's my tidal, which you can't really think about it and do it. It's not accurate, but and then more. Okay, that'd be expiratory reserve. Even if you blew out everything you think you could, there's always going to be some circulating in your lungs, and that's called your residual volume. Okay, and so it just recycles. Now the vital capacity is how much you can. It's basically a combination of tidal, inspiratory, and expiratory reserves. So it's like you take the deepest breath possible. So that would be tidal and inspiratory, right? Inspiratory reserve, and then exhale everything you think you could. That amount that you can exhale is your vital capacity. In lab, we'll have a little instrument called a respirometer, and we won't do that today, but when we do the lab on the respiratory system, you'll get a chance to measure your vital capacity and compare that to vital capacities of other people of your age and height and gender. Okay, we'll have tables we'll look at for that. So that's interesting. Okay. Then the total lung capacity is a combination of the residual and the vital capacity. Okay. Um, so so that's like the capability, the capacity. All right. So some of this you can calculate mathematically. Other is just this amount you inhale or exhale. Okay. All right. Um, and then here you see all of them. If you were, you'll probably have a unit of this if you're going into nursing, or especially if you're in respiratory therapy. This is what you learn completely. And some of these are actual volumes that can be calculated. Others are capacities that you calculate mathematically using two or more of the volumes. Okay, but these are indications of lung function. Yeah. People who have diseases that affect the lungs, it affects some of these volumes or capacities, like emphysema, asthma, all of that affects this. Your book gives a good bit of time or pages to that, to the more details with this. I'm not going to test you on many details on this. Okay, just what's on the page before. Make sure you can define each of those. Okay. All right. And then this chart, this graph is showing you, how these volumes compare to each other. So here, like, if you looked at this part right there, that's the vital capacity. So you see it's a combination of the tidal, which is this, and then the inspiratory and expiratory. You can see that. I should circle it like that. Okay, so it's all of that. Okay. Then our respiratory system is involved in air movements other than those associated with breathing. Okay, and that's what this is talking about. So I would like for you, there's another table that you can look at on page 749. But I need you to know the function and mechanism involved in each of these, the function and the mechanism involved. So with coughing, you know that hacking sound we associate with coughing? That's when the glottis is closed. What is the glottis? If you've studied, exactly, the opening between your vocal cords. So when all that's closed up, and if you make a sudden rush of air, force of air up towards it, that hacking sound, that sound, that's that glottis, that's the vocal cords vibrating when they're tight, close together. Um, Sneezing is kind of the same thing, but in coughing, all of that air channels out through the mouth, and sneezing it channels through the nasal cavity. So the function of those, coughing clears part of the lower respiratory tract, and sneezing clears the upper. Okay. Pardon me? You haven't thought about where the air's going? Yeah, yeah. And then if you look at the mechanisms of laughing and crying, they're very similar, if not identical. And both of those are relieving emotional stress. Um, and hiccuping, nobody really knows why we hiccup. There's no real function for hiccuping. But basically, what's going on is a nervous system issue where the phrenic nerve, remember the phrenic nerve goes to the diaphragm? It's sending impulses kind of spasmodically, just quick impulses. And so it causes that diaphragm to lower quickly. And every time it lowers, you're going to inhale, aren't you? So it's like that. So anyway, it's a nervous system issue. You yawn because somewhere in your body you need some more oxygen. So that's just a way to help you get more. Please don't ask me why you yawn if somebody else does. I don't know. Okay. And then speech, we've already talked about speech with the vocal cords, with air moving up. And the sound that you hear, initially just comes from the vibration of the vocal cords. But then how those sound waves channel, or how your pharynx and your mouth, your tongue, your teeth, your lips, how all of that is positioned determines how the sound comes out. Okay. You don't have to explain all of that, but anyway, speech is due to the vibration of those vocal cords. Okay. Initially, that causes the sound wave. Okay, then here's an example of some of these clinical applications, which I'm not going to test you on these. But some of you may struggle with asthma, or you may know somebody who has asthma. And I think basically what goes on with asthma is that the airways, the bronchial tubes, are too constricted, and so that limits how much air can move into the alveoli. So do you see how it limits the gas exchange? So many of the medications for asthma have to do with dilating those airways or relaxing those muscles. A lot of those are just smooth muscle relaxants. Emphysema, when somebody has emphysema, this is interesting. You've heard of emphysema probably, right here. You remember how the alveoli are clustered? It's like a little cluster of grapes. A lot of times they merge into one huge sac instead of a bunch of little ones, which decreases the surface area. So even though the alveoli are big, that means the surface area is not as much. So just imagine, I know I can't draw this right, but there's a bunch of alveoli. If you measure that blue line, if that was all merged together like this, the blue line in B, the person who has emphysema, is less length than A, the person without emphysema, right? And so that's less surface area for the gas exchange. Okay. But again, you're not going to be tested on these, okay? But a lot of you hear about COPD down at the bottom. That's chronic obstructive pulmonary disease. A lot of diseases that affect the gas exchange because it limits the amount of air getting to the alveoli, or it limits there's a limit to the surface area. That's going to cause somebody not to be able to get adequate oxygen in their blood. And so that's chronic obstructive pulmonary disease. You hear about that a lot, COPD. They advertise all these expensive medications for COPD. So, all right. Now we're going to look at your nervous system and how it controls your breathing, your depth and your rate of breathing. And that's through an area in your central nervous system called the respiratory center. It's in two places. Part of it is in the pons of the brainstem, and part is in the medulla oblongata. The part in the pons is called the pontine area, and the part in the medulla is the medullary rhythmicity area. And within that area, you've got a dorsal and a ventral group. And this is a real complex interaction between neurons between these two groups, and they work together to control the rate and the depth of breathing. Okay, here you can see on this picture, you can see the pontine area close to in the pons there, and then here's the dorsal and the ventral groups of the medullary rhythmicity area. To make your life a little easier, if you will just basically the pons is the main one that regulates the rate, and then the rhythmicity area does what it says. It regulates the rhythm, how long the inhale is compared to the exhale, the rhythm of the breathing, okay, or the length of time between inhaling and exhaling, the rhythm of breathing. But if you look at this flow chart, which is not, this is basically to show you that they interact with each other. They don't work independently. So the pontine area sends impulses to the rhythmicity area, which in turn, each of its groups send impulses to, say, through the phrenic nerve, to the diaphragm, to the nerves going to the external or internal intercostal muscles. Okay, so that regulates that breathing. Okay. Now, as we look at the movement of the gases, all right, we're going to be talking about this term, this aspect of gases called partial pressure. Now, we've talked about air pressure, right? Air pressure. All right, but you realize air is a mixture of a lot of gases. Did you know that? Oxygen and CO2, but do you know what gas is mostly in air? Nitrogen, okay, which really doesn't do anything in us. It goes in and it goes out. All right, but the pressure exerted by each individual gas in an amount of air is called that gas's partial pressure. For example, if atmospheric pressure is 760 millimeters of mercury, which is basically what it is at sea level, okay, then that doesn't mean oxygen exerts that much pressure. The amount of oxygen in air is about 21%. So if you said 21% of 760, that would be 160 millimeters of mercury. That would be the PO2, which is partial pressure of oxygen, PO2, partial pressure of oxygen, okay? All right, and we're going to see that that's what's used, the partial pressure is what's used to determine where the oxygen moves. Does it go from the alveoli into the blood or the blood to the cells? It has to do with not total air pressure, but the partial pressure that each gas exerts in that mixture of gases, okay? So partial pressure is just the pressure that each gas contributes to the mixture, okay? So we'll come back to these partial pressures as we look at these gas movements. A lot of things can affect these the breathing itself, and I want you to spend a lot of time studying this part. Okay, a lot of things can affect our breathing. So we're going to go back now to that the respiratory center. So in other words, a lot of factors in your body will cause impulses to go to your respiratory center, which in turn will react by sending either sympathetic or parasympathetic impulses to speed it up or to slow it down. Okay. All right. One of the things is the partial pressures of the two gases involved, of oxygen and of carbon dioxide. Okay, in your blood, that's going to affect your rate and depth of breathing. We'll see that in a little while. We're just listing them here. But then the stretch receptors in your lung tissues and in the walls of your thorax, they're going to affect the rate and the depth of breathing. Um, your emotional state affects your rate and breadth of breathing, doesn't it? Yeah. And then your level of activity. You know, when you exercise, you breathe more, right? Okay, so all of those things, those factors can cause impulses to be sent to your respiratory center. So some of these are just some mechanoreceptors, like some of the stretch receptors in your lungs. When they get stretched, it's going to send an impulse to make you exhale. Okay. Um, and then you've also got some chemoreceptors. This should be central and peripheral chemoreceptors. That should be right up there. I don't know why it went went down when I typed it. Okay. Um, the main things, and this is what I put in blue here. The main things are the partial pressures of carbon dioxide, and this is weird, of hydrogen ions affect your breathing rate. That's weird. We're going to see how that is. So that's some of these chemoreceptors. You have some chemoreceptors for oxygen in various blood vessels. You have chemoreceptors for carbon dioxide and hydrogen in various places of the body. But their levels will affect basically your breathing rate. Okay. All right. So let's kind of flesh out some of this. Okay. First of all, the stretching of tissues. You've got stretch receptors. These are some of those mechanoreceptors that are referred to. They're in various places around the lungs or within the lungs, and when you inhale, they get stretched, and they don't just keep stretching. At some point of stretch, they're going to send an impulse to your respiratory center that prevents further inflation. So that's called the inflation reflex. A lot of times when you see a word in front of the word reflex, that means that's what that reflex prevents. So the inflation reflex prevents too much inflation. Okay? It doesn't cause inflation, it prevents more. Okay? All right. And so this is picture just showing you where some of these stretch receptors are, and see they're sending impulses to that respiratory center. And then if we look at these chemicals in your blood, you have receptors in your various blood vessels and also in the respiratory center itself that are sensitive to these levels of chemicals. Okay? And when I say low oxygen, technically it's low partial pressure of oxygen. It's just easier for me to type up low oxygen rather than do my superscripts and subscripts, and it just gets really complicated typing it. But I'm talking basically about partial pressures, but it's okay for you just to say low oxygen. Okay. All right, you've got chemoreceptors in your carotid arteries, which are some arteries that branch off the aorta to go up to the head. And you've got chemoreceptors in the aorta itself. Where it says carotid and aortic bodies, that's just little swollen areas in the wall of that blood vessel where these chemoreceptors are, where they're sensitive to decreases in oxygen levels in your blood. And you probably figure out if your oxygen is low, you probably need to breathe more, right? And so as they get activated, as these chemoreceptors get activated, they're going to send a signal by way of a nerve impulse to your respiratory center, which is going to respond by increasing your depth and rate of breathing. That makes sense, doesn't it? Yeah. But look at this. You also have some chemoreceptors that are sensitive to carbon dioxide levels, partial pressures of CO2. And when they go up, see, it's low oxygen but high CO2. When it gets up, don't you realize that normally, in normal conditions, if oxygen is low, CO2 is high? Do you get that? If your cells have used oxygen, they've used it in cell respiration, haven't they? And a byproduct of cell respiration is what? CO2. So then that CO2 moves into the blood. So as The blood oxygen lowers, the blood CO2 rises. Does that make sense? So do you see how indirectly an elevated CO2 is an indication that you don't have enough oxygen? So an elevation of CO2 will also cause your breathing rate to increase. That makes sense. Do you see that? But I want you to notice where the chemoreceptors for oxygen and CO2 are located. Where are the chemoreceptors for oxygen located? In blood vessels that are not in your central nervous system, right? So that means there's a lag time to get the impulse to go to your central nervous system, right? Where are the chemoreceptors for CO2? Right there in the respiratory center. So if they get activated, do you see how the respiratory center's response is quicker? Because there's no lag time. It doesn't take, it's already there. Okay? All right. Also, the receptors, chemoreceptors for oxygen, don't get activated unless oxygen levels drop by about 50%, I believe. So it takes a big drop. Whereas the CO2 receptors are super sensitive to just a little bit of an elevation of CO2. Okay? So do you see how your respiratory center responds more quickly to changes in CO2 than it does oxygen? Okay. So where in the world does hydrogen ions, where does that come into play? Okay, it has to do with this reaction right here. When carbon dioxide gets in a watery environment, it's going to combine with water. And a place that is a very watery environment is your blood plasma, right? So in your blood, carbon dioxide combines with water to form, this is carbonic acid, which is a fairly weak acid, but because it's an acid, it dissociates into hydrogen ions and then a negative ion. And this negative ion is very famous in anatomy and physiology. It's called the bicarbonate ion. The bicarbonate ion. That's the main way CO2 travels in your blood, is in the form of a bicarbonate ion, because CO2 immediately combines with water to form carbonic acid, which splits up into hydrogen ions and bicarbonate ions. So do you see that the level of CO2, if it goes up, so does hydrogen? Do you see that? So if you go back to the top where I've put normal up here, when oxygen is down, CO2 is up, and as soon as it goes up, what else goes up? Hydrogen goes up. And there are chemoreceptors that are sensitive to hydrogen levels. In fact, they're most sensitive to changes in hydrogen. Okay? And so if the hydrogen ion level increases, then your breathing rate's going to increase. Okay? So that's where hydrogen plays a role in it. Okay? All right. So here you see there's the aorta, and these are some receptors in here in the walls of the aorta. Here's some receptors in the carotid arteries. So those are the ones that are sensitive to oxygen drop. But it takes quite a bit of oxygen drop. Okay. All right, so if we look at, this is what I've said. Normally, when oxygen's high, CO2 is low. And when oxygen is low, CO2 is high. And you also realize that whatever CO2 is, so is hydrogen. So if CO2 is low, hydrogen's low. If CO2 is high, hydrogen's high. Because that little reaction we just went through, it can reverse. It's a reversible reaction. It has to, so that you can breathe out CO2. You know, so if CO2 drops because you've breathed it out, that means as hydrogen has combined to form this, Okay, so whatever CO2 is, hydrogen is. Keep that in mind. Whatever CO2 is, hydrogen is. Always. Okay? Okay. All right, so let's think about some conditions or situations in you that can change your CO2 levels. Okay? So let's say when you exercise. So how does exercise affect your CO2 levels? Remember, if CO2 is low compared to if CO2 is high, if CO2 is high, what's that going to do? It's going to increase the rate of your breathing in depth. So if CO2 is low, it does the opposite. It decreases the rate and depth of breathing. Okay, so let's look at some changes things that can cause changes in CO2 levels. When you exercise, what happens to your carbon dioxide levels in your blood? Does it go up, down, stay the same? It goes up. When you exercise, you're undergoing a lot of cell respiration in your muscles, right? And so you're producing a lot of CO2 in your cells, and that CO2 moves into your blood. So that elevates your blood CO2. So as you exercise, CO2 is up, and you also know oxygen is down because you've just used it. But what your respiratory system is looking at is the CO2. And then in turn, hydrogen's going to be up. Okay, and so I'll put in parentheses, hydrogen's up, because CO2 and hydrogen are always the same. So that causes the breathing rate to do what? Increase. Okay? All right, increases. All right, so what if you hold your breath? What happens to your CO2 level when you hold your breath? Goes up, goes down, stays the same. When you hold your breath. It goes up. When you hold your breath, you're not taking in oxygen, are you? But that doesn't mean cell respiration has stopped in your cells. So what are you continuing to produce? CO2, it gets in your blood and you're not breathing it out if you hold your breath. So do you see how your blood CO2 rises? All right, and so how's your breathing rate going to respond to that? So oxygen goes down, which is a little bit irrelevant what the oxygen is doing. CO2 rises, so that means hydrogen rises. And so what happens to your breathing rate after have you ever realized that there's a limit to how long you can hold your breath? At some point in time while you're holding your breath, you've got this undeniable urge to breathe, don't you? And so you have to breathe. That's your respiratory system kicking in. And when you start breathing, it's going to cause your breathing rate to increase. Okay? Think about it. Increase compared to your just normal resting breathing rate. Okay? So there's no way somebody can kill themselves by holding their breath. Because at some point they're going to have this big old urge to breathe and their will cannot override that respiratory center. Okay? Now, while they're holding their breath, look at this. Look at the oxygen levels. It's continuing to go down because whatever oxygen was in the blood is continuing to move to your cells. At some point, when oxygen levels drop enough, that may cause a person's blood vessels going to the brain to dilate, which drops their blood pressure in their brain, and they'll pass out. But as soon as you pass out, your respiratory center kicks in. So unless they hit their head on something and die that way, there's no way you can die by holding your breath. Okay? All right. All right, let me erase this. Okay, so what about if you hyperventilate? Y'all know what hyperventilating is? Your book says it's something like deep rapid breathing, but to me it's you exhale more than you take in. You exhale more volume than you take in. So when you hyperventilate, what happens if you, listen to me, exhale more like my inhale is not as big as the exhale. Okay? So what's happening to my blood oxygen levels if I'm exhaling more volume than I'm taking in? The O2 goes down, right? Your O2 drops. But if I exhale more than I take in, what else is dropping? CO2 also drops. See, this is not normal. This is when both of them have dropped because I'm not taking in enough to accommodate the CO2 that was lost or produced. Okay? So if CO2 drops, what else drops? Hydrogen. It always is the same. Regardless, it's always the same as CO2. So at a time when your body needs oxygen, your respiratory center, though, is responding to the CO2 and the hydrogen. because of the location of the receptors, basically. They're right there at the respiratory center. And so it's going to do what it always does when CO2 drops, and that means the breathing rate will decrease rather than increase. And that's why when a person has hyperventilated, they feel like they cannot breathe because their respiratory center has been suppressed or depressed. Okay? Anybody ever truly hyperventilated? Sometimes if you're exercising a whole lot and you get super winded, especially if you're dehydrated, you can hyperventilate. Well, you see that with athletes sometimes. But you could hyperventilate, just because you're crying a whole lot, just sobbing. Sometimes that sobbing is exhaling more than you take in. Women who are in labor or in other degrees of pain, people who are in a lot of pain, a lot of times will hyperventilate. All right, and they feel like they cannot get enough air. And it's simply because their respiratory center is suppressed because of the drop in CO2. Okay? So it's really quite a struggle for a person. The old way to remedy that, do you know what it was? To have that patient breathe into a paper sack. Because if they do you see how that very quickly makes the CO2 levels rise? Because if you're breathing into a bag, that means you're inhaling the CO2 you just exhaled. You see? And so that's going to up the CO2, which is going to activate your respiratory center. You can start breathing. Today, they say that's too drastic of a change, that it's much better to try to get the patient to calm down and take slow, deep breaths so that the blood gases can work themselves out. Okay? But that was the quick fix. Way back, when I was expecting a baby, they, we went through those little Lamaze classes, and they gave you the list of what to pack in your little suitcase to be ready when you went into labor. But one of the things they told you to put in there was a paper bag. I'm serious. That was in case you hyperventilated during the labor. And then, anyway, okay. So basically, it's tricking the brain. Okay. And then this the low oxygen can also cause some loss of consciousness. If somebody's hyperventilated a lot, they might faint because they could lose consciousness. So that's why, like, if you try to make yourself hyperventilate, like, at some point you can start feeling dizzy. I feel lightheaded already. It's because the oxygen levels are dropping a little bit. So, and I did not just hyperventilate. You have to do that for a couple of minutes, but at some point you might really feel like you're struggling with it. Okay. Some, you ever noticed, we'll get to exercise. We've already talked about exercise actually, but have you ever noticed when you go swimming, especially when you're little, you always like to compete with your friends to see who can stay underwater the longest? And some kids have figured out that if they do this first before they go under, they can stay under longer. Tell me what they've just done. I just breathed out more than I breathed in. So they have dropped their CO2 level. I mean, they don't know they're dropping their CO2 level. They just have figured out that if they do that first, they can hold their breath longer. It's because their respiratory center is suppressed and they don't have the urge to breathe. But what's the danger of that? They could pass out. And if you're underwater and you pass out and your respiratory center kicks in, you drown. So that's not a smart thing. But, it's not. There have been people who have died, usually not little kids playing around like that, but athletes who are swimmers have figured out, every time you raise your head, that takes a few milliseconds or whatever. It increases your time, doesn't it? So some have figured out if they do some of that breathing ahead of time, they can go longer before they take a breath. But have you ever heard of shallow water drowning? And it happens with swimmers sometimes. It really does. And they don't realize that their respiratory center is so suppressed. They don't have the urge to breathe, but then they pass out and they're right there, their face is in the water. So shallow water drowning, and read up on it. It's scary. It's really scary. Exercise. We've talked about how exercise affects your CO2 levels, that causes your breathing rate to increase. But you also have some of these joint reflexes, which are mechanoreceptors in your joints. You remember your Golgi tendon organs and your muscle spindles, those things, the spindles especially. They're going to affect it. Okay. So, we've talked about some body conditions that can affect your breathing center, your respiratory center. But now we're going to talk about where the gas exchange is actually taking place. That location is described as being your respiratory membrane, which of course is at the alveoli. You know that. In order for gases to move across a respiratory membrane, that membrane has to be super thin. So that's why it's important that each alveolar sac is simple squamous, and the blood capillary is simple squamous, and then there's a little fibers in between that's referred to as a basement membrane. Your book may say a non-living basement membrane. Non-living just means it's not made up of cells, just little fibers, and things move in between them like gases. All right. Some animals' respiratory membranes would be their skin. Did you know some animals don't have lungs? They breathe through their skin, like an earthworm. You ever, when you were little, did you dissect an earthworm? No? Y'all never had a biology? They don't do any dissections anymore, do they? That is just a shame. But earthworm's skin is super, super thin, but it's also wet. You know, these little worms, if they don't need to be in water, so if it rains one night, the worms that are in the ground are going to come up because they will drown if it's too much water. So they come up, they get on the sidewalk, then they dry up and they die. That's because their respiratory membrane has gotten too dry. Okay, it has to be slick. Because the gases have to be dissolved in a little bit of water in order to cross the membrane. A frog. Did you know a frog can breathe through his skin? Now, frogs have lungs, but they also have a real thin skin. That is their respiratory membrane. It's one of their respiratory membranes. So, anyway, yours is definitely not your skin because it's not simple squamous, is it? It's not wet. All right, so yours is at your alveolus, and you know that. So here it is, and you can see the simple squamous of the alveolar sac, and then you can see the little blood vessel around it. And you can see that oxygen moves from the alveolus into the blood, and CO2 moves from the blood into the alveolus. Okay. And you can see it again on this picture. You can see it a little up close. So here you're seeing a blood capillary, a cross-section view of a blood capillary, and there's the simple squamous. There's the simple squamous of the alveolar sac. And you can see there's macrophages. You've got macrophages that are resident macrophages in your lungs. And you actually have two kinds of cells that make up the wall of the alveolus. On this picture, it shows you the type 1. That's the regular squamous cell, but the type 2 is the one that produces surfactant. Remember surfactant? You don't have to know type 1, type 2, but that's the difference in those. Why do you have surfactant? What is it chemically? Is it a carbohydrate? It's a lipoprotein. A lipoprotein. So it's a combination of a lipid and a protein. And what does it prevent? Total collapse of an alveolus. It keeps it open. Okay. Why would an alveolus collapse if you did not have surfactant? Not air pressure, not partial pressure. It has nothing to do with pressure. Surface tension of the water molecules that are lining the alveolus. Okay? All right. So this gas exchange, here we're getting back to these partial pressures. The gases move You know, gases always move from an area of high pressure to low, right? Air is a mixture of gases, all right? But each individual gas moves across the membrane because of the partial pressure of that gas on one side is greater than the partial pressure of that same gas on the other side. So the pressure of CO2 in the blood has nothing to do with oxygen's movement. And the pressure of oxygen in the blood or the alveolus has nothing to do with the CO2 movement. Okay? That's what I'm trying to get at. All right. And so I've already defined partial pressure for you. But individual gases in a mixture of gases move from an area of high partial pressure to an area of low partial pressure. So here you can see at an alveolus, if you look at the incoming blood from the right ventricle, remember that's the deoxygenated blood. Look at the partial pressure of oxygen. See how it's in the incoming blood at the lungs is 40 millimeters of mercury, yet the partial pressure of oxygen in the alveolus is 104 millimeters of mercury. And so because 104 is bigger than 40, that's the reason that oxygen moves in and no other reason. Okay? Look at the partial pressures of CO2. In the incoming blood, it's 45, but in the alveolus, it's 40, and that is the only reason that CO2 moves into the alveolus. Okay? All right. So partial pressure of CO2 has nothing to do with oxygen's movement and vice versa. Make sure you know that. Okay? Okay, so let me turn these speakers on. Now, the same thing's going to hold true, you're going to see on this video, when the blood gets to the tissues. It's the partial pressure of each individual gas at the tissue level that determines the direction of movement of that gas.
Fresh air entering the lungs carries oxygen to the alveoli. The amount of gas in air or of gas dissolved in a fluid can be expressed as partial pressure, which is measured in millimeters of mercury. The partial pressure of oxygen in the air within the alveoli is 104 millimeters of mercury. Carbon dioxide that enters the alveoli from the blood causes the carbon dioxide concentration in the air of the alveoli to be 40 millimeters of mercury. Carbon dioxide is continually removed from the alveoli as air is expired. Blood coming from the heart at the arterial ends of the pulmonary capillaries has a partial pressure of oxygen, or PO2, of 40 and a PCO2 of 45. Therefore, oxygen diffuses from the air in the alveoli into the blood, and carbon dioxide diffuses from the blood into the alveoli because of these differences in partial pressures. Oxygen and carbon dioxide diffuse until there is no difference in partial pressure in the air and the blood. At this point, there is no more net movement of O2 or CO2. Therefore, at the venous ends of the pulmonary capillaries, the PO2 in the blood and alveoli is 104, and the PCO2 in the blood and alveoli is 40. Some oxygen was removed from the blood to nourish lung tissue. Therefore, the PO2 in arterial blood leaving the heart is 95. Oxygen diffuses out of the arterial ends of tissue capillaries into the tissue fluid, then into the cells, and carbon dioxide diffuses out of the cells into the tissue fluid, then into the blood because of differences in partial pressures. At the venous ends of tissue capillaries, the PO2 in the blood is equal to the PO2 in the tissue fluid, and the PCO2 in the blood is equal to the PCO2 in the tissue fluid, resulting in no more net movement of O2 or CO2. The blood now carries the O2 and CO2 to the lungs. In the body, all of these exchanges occur simultaneously.
Okay, this video, I should just remove it. It says exactly the same thing, so I'm just going to bypass it. Okay. All right. Okay, so now once these gases are in your blood, okay, we're going to talk about how they're transported in the blood plasma. Um, so look at this. As the gases enter the blood, they do one of two things. They dissolve in the blood plasma, or they undergo a chemical reaction to be in some combination, to be in another, to be part of a molecule or another ion, polyatomic ion. Um, so what that means is, let's say if here is a blood vessel, and these numbers are not accurate, okay? But let's say oxygen's going to move into a blood vessel at the lungs. All right, there is a limit as to how much oxygen can dissolve in the blood plasma. You know, there's a saturation limit. But your body needs more than that amount. So oxygen, you know, what does come in is just dissolved, but any excess then is going to combine with other molecules. Okay? And so that's what this is talking about. So you always have a saturation point. Anything beyond that is going to, and you need a whole lot more than that. Okay? It's going to combine with something else. So if we first look at oxygen transport, a very small amount is just dissolved in the blood plasma. By far, most of it combines with the hemoglobin molecule in your red blood cells. Do you remember hemoglobin can hold 4 oxygens? It's got 4 heme units. In the middle of each heme unit is an iron, and the oxygen attaches to the iron. Um, so, so if here's that blood vessel again, and let's say here's a red blood cell, and here's hemoglobin. Remember, a third of the volume of a red blood cell is devoted to hemoglobin. Okay, so it can hold a ton of oxygen. So you get, let's say our oxygen saturation is 5, which is not true, but you've got oxygen there, 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 there. Now, as soon as it reaches that saturation, some of it is going to come into the red blood cell, combine with hemoglobin to form oxyhemoglobin, which makes that hemoglobin molecule bright red. Okay, and as long as it keeps channeling in, that frees up space so more oxygen can dissolve. So it dissolves and moves in. It dissolves and moves into the blood and blood cell. Do you see that? Okay. And then go down all the way. Here's the tissue level. So here's a body cell that needs that oxygen. Here's a red blood cell that has the oxyhemoglobin in it. What happens is the oxygen that is directly dissolved that's the one that's giving the blood its partial pressure, and that partial pressure is greater than the partial pressure of oxygen in the interstitial spaces. So this oxygen moves out of the blood into the interstitial spaces, and then that partial pressure there is higher than what's in the cell, so it moves into the cell. Okay. In the meantime, that frees up a spot for oxygen to dissolve, doesn't it? And so that then that lowers the partial pressure of oxygen in the blood, and that's one of the many triggers for hemoglobin to let go of that oxygen to do the reverse reaction to become deoxyhemoglobin, so the oxygen can go back into the dissolved state and then be able to move to the cells. So it's constantly going back and forth and back and forth. Several conditions of the body can affect the release of oxygen from hemoglobin. For example, a low oxygen level in the blood plasma, which is also indirectly, it can be caused by a high CO2 level, you know, because the oxygen is being used, CO2 is being produced at the cell, so CO2 goes up. So as the CO2 level rises in your blood, then oxygen lets go of even more hemoglobin than it would when the CO2 was low in the blood. Okay? If the acidity increases, remember acidity is due to the presence of hydrogen ions. The more hydrogen, the more acidic. And isn't that an indirect indication of what the CO2 is? Anything that affects the acidity of the blood, and there are a lot of things that can affect the acidity besides CO2. We'll talk about those in another chapter down the road. But an elevation in the acidity, which is a drop in pH, is going to cause hemoglobin to let go of more oxygen. because that's an indication that there's not enough oxygen, right? Because normally when hydrogen and CO2 are up, oxygen's down, right? Okay, and then an elevated body temperature can cause hemoglobin to let go of oxygen more easily. Okay, I'll come back to this last statement in a moment. Um, so I don't know that I have. Like here's hemoglobin's the saturation curve for at different um, oxygen PO2s, oxygen levels in the blood. All right, and um, so as you have a higher amount of oxygen in the blood, do you see how that can affect the dissociation of oxygen from hemoglobin, that oxyhemoglobin dissociation? Um, and that's at one body temperature. Body temperature can affect it. So these are kind of some famous what we call hemoglobin dissociation curves. And do you see how the amounts change? Like on this top one, this is showing you at the various partial pressures of CO2. So do you see how it dissociates more quickly at at various CO2s, or it doesn't hold as much? I guess I should say it doesn't hold as much. Um, like this doesn't hold as much as these do. Okay. You won't have to analyze these. This is one of the trickier things in this chapter, these dissociation curves. In your respiratory units down the road, you may look at these in other classes a lot more. Um, Here you can, this second one is showing how the blood pH change affects the release of oxygen from the hemoglobin. Um, so do you see what this means? Like these are various pHs. Do you see how this is more oxyhemoglobin than this is? See, the lower the pH, that means the hemoglobin, the oxyhemoglobin is going to dissociate to release oxygen more quickly. That's what that's talking about. Um, and then temperature, if here's it at different temperatures. See how more oxyhemoglobin is formed at low temperatures than at high temperatures. Okay, so it lets go more easily. It's very important that hemoglobin lets go of oxygen. It's very important because if not, then just that oxygen, like just this oxygen, is the only that's immediately available to your cells. And so once it moves, if oxygen doesn't come off of the hemoglobin in your blood cells, then your cells aren't going to get any oxygen. So it's very important that oxygen dissociates from hemoglobin. Y'all got that? It's very important. Okay. But now let's look at this last statement here. Hemoglobin has a higher affinity for, y'all know what this is? It's not a typo. That's not supposed to be CO2. That is carbon monoxide, not carbon dioxide, carbon monoxide. All right, you hear about carbon monoxide poisoning, don't you? Okay. Hemoglobin loves to have oxygen attached to itself. But if it has a choice between oxygen and this carbon monoxide that is not supposed to be in you, every time it's going to choose carbon monoxide. It has a stronger attraction for carbon monoxide than it does for oxygen. And once carbon monoxide binds to it, oxygen can't bind. And it doesn't let go of carbon monoxide very easily, like it does, thank goodness, with oxygen. It lets go of oxygen. All right, and so if somebody is exposed to carbon monoxide, let's say they're in a home and their gas furnace is malfunctioning, and it's carbon monoxide is a normal byproduct of fuel combustion, like in your car or in your gas furnaces at home, your gas appliances. All right, and they are equipped with devices that take up the carbon monoxide or change it into forms that don't hurt you. But carbon monoxide is a clear gas. It's odorless. It's colorless. So you don't know it's there. But if you're breathing it in, it's going to take up the binding room for oxygen that oxygen would normally go to. And so over time, you're going to lose consciousness because your oxygen levels have dropped and you won't wake up. Okay, that's that carbon monoxide poisoning. So that's why it's important, um, if you are with other folks in a home and you're all starting to get real sleepy, all kind of at the same time, that's an indication of carbon monoxide poisoning. So just get outside. That's the best remedy. The quickest one is to get outside. You don't ever want to be in an enclosed garage with a car running, because carbon monoxide is part of that car exhaust. Um, so, at a hospital, how do they treat carbon monoxide poisoning? Do you know? Put them on 100% oxygen, right? When to try to flush it off. If you were just like people who have to have oxygen, you see some people with pulmonary issues and they have to carry around a little tank of oxygen with them all the time. That is usually not pure oxygen. It's get like air. It's a mixture of gases. Okay, but if somebody has carbon monoxide poisoning, they'll try to treat that with administering a tank of pure oxygen, and that massive influx of oxygen, because of the extreme difference in partial pressures, not just a little difference, a big difference, makes more oxygen move in, and so hopefully that'll flush off the carbon monoxide. Okay. And it doesn't always work. It just depends on how severely affected the person is, how much carbon monoxide they took in. Okay. But this is showing you what the video did. It's just showing you the movement. So you might want to spend some time in your book, talking through that. You will not have to give me any of the numbers for partial pressures. Don't worry about memorizing any of those numbers. You just need to know that at the tissue level, the reason oxygen moves out of the blood is because its partial pressure is greater in the blood than it is the tissues, right? And the reason CO2 moves into the blood from the tissues is because the partial pressure of CO2 is greater in the tissues than it is the blood. So it moves in. Just make sure you know that those. And I've spent way too much time on that. But some people just get really thrown off by the term partial pressure, and you don't need to. The point I'm trying to make is it doesn't matter what the partial pressure of one gas is as to what the movement of the other gas is. Does that make sense? It's always partial pressure of oxygen on each side refers to oxygen movement, and so forth. Okay. All right, now how does CO2 get transported? Like oxygen, some is dissolved in the plasma, but not a whole lot. Some of it actually moves into your red blood cells and also binds to hemoglobin, but it's not like carbon monoxide binding, because it doesn't bind to the same place the oxygen would bind. So it doesn't interfere with oxyhemoglobin. Okay? So it's okay. And it lets go of that. But most of it, by far most of it, is in the form of the bicarbonate ion, because of this reaction I talked about earlier today. Whenever carbon dioxide gets in the bloodstream, it combines with water to form carbonic acid that then splits up into hydrogen ions and then bicarbonate ions. And the bicarbonate ion is the main way carbon dioxide is transported. But thank goodness that also is a reversible reaction, because you've got to be able to breathe out the carbon dioxide. Okay, so this is showing you CO2 produced in your cells. Some of it goes in the blood, just dissolves to give the blood its partial pressure of CO2. And then some of it moves into the red blood cells to form carbaminohemoglobin. Anyway, that's the carbon dioxide combined to the hemoglobin. But the bulk of it actually moves into a red blood cell, where it combines with the water to form the bicarbonate ion and the hydrogen. And then the bicarbonate ion then moves out into the bloodstream, into the blood plasma. Okay. And so that's the bulk of it. All right. When that blood then makes its way to your lungs, the opposite happens. That is dissolved in the plasma just moves out. And so that frees up place for more to be dissolved. So that's why a bicarbonate ion is going to move into the blood cell and combine with the hydrogen to form the acid that breaks up into CO2 and water. The CO2 comes out here because it can dissolve and then it moves out. Okay, and the same thing true with the hemoglobin lets go of carbon dioxide and it moves out. Okay. All right. I think this is interesting. I just skipped through this a moment ago. Do you remember? I know you do. In A&P1, when we were talking about a nerve impulse, let's say if here's a neuron, remember you had sodium on the outside and what on the inside? Potassium. And when sodium moved in, what moved out? Potassium moved out. And the whole point of that was to keep this membrane of the same potential charge. Okay, so something positive came in, that's followed by something positive going out. You see that all over the body. Cell membranes try to keep the charge. And here's a classic example in your blood cells called the chloride shift. And it has to do with the bicarbonate ion. When it's moving out of a red blood cell to go into your blood plasma, another negative ion moves in, and vice versa. If it moves in, then a negative ion is going to move out. And it's chloride ion that correlates with that one. That's not on your test, but it's interesting. It's interesting to me. But we see examples of that in other places too as we go through A&P. Okay, we're done with your notes, but I want to talk to you about something else that's pretty interesting that has to do with this saturation in your blood. Have you ever heard of divers, like scuba divers, having the bends, BENDS, the bends? Y'all had never heard of that? Oh, do any of you scuba dive? None of you do. I don't either. That's my goal in life one day is to learn to scuba. Yeah, but huh? Yeah, me too at the time. All right. Remember, I said there's a limit to how much oxygen can dissolve in your blood plasma. Okay, here's a blood vessel, and let's say here's the limit is 5. 5 oxygens can dissolve. All right, and that's at sea level, which is basically where we are right now. You know, that much can dissolve. When you dive deep in the water, that water pressure around you increases the deeper you get, doesn't it? And that water pressure around that diver is allowing his blood to have a higher saturation of dissolved oxygen. So instead of 5, it might be, let's put just for my purposes, 3 more. So it can hold more oxygen, which is fine. Doesn't hurt him a bit, not a bit, as long as he stays down there. Okay. But if he starts coming up too fast, that external pressure is less. And so that means that some of this oxygen can't dissolve anymore, and it's not dissolved, so it bubbles as gaseous oxygen, not dissolved liquid, gaseous oxygen, which can wreak havoc in the body, especially in the nervous system, but also in the muscles. It can lodge in tissues, and it can cause that diver to hallucinate. He doesn't know what's up and down. That's now you've heard of that, haven't you? When divers come up too fast, that condition's called the bends, and the way to prevent that is to come up slow enough to give this oxygen time to go somewhere before it bubbles. Does that make sense? Okay. So how they treat a diver who's come up quickly, or even if they hadn't come up quickly, if they go down deep enough, they're just going to automatically do this on the ship. They put them in a decompression chamber. And so it's a little room on the ship that air pressure can be controlled, and he sits in there for a few hours while the air pressure is gradually increased, which is mimicking the water pressure when he was down low. So it increases so that anything that is bubbled can go back into solution. It can go dissolve. Okay? And then over the next few hours the air pressure is very gradually decreased so that this oxygen um, can can easily move on into the tissues before it bubbles again. Does that make sense? Okay, so you might wonder, why are we talking about that in this class? All right, the reason is because I think it was, I don't know if it was World War I or World War II. Doctors on the battlefield figured out that if they could put the soldiers who had these horrific wounds in a decompression like chamber, it would cause those wounds to heal more quickly. Um, and the reason it caused the wounds to heal more quickly is because it flooded the tissues with oxygen. There was a bigger difference in the partial pressures. So more oxygen could move to the cells and they could heal more quickly. Does that make sense? Because on the battlefield, they can't perform surgery real quick. And so they had these awful, awful wounds. Well, today that's put not just in with soldiers, it's in medical settings. It's called hyperbaric chambers. And um, if somebody, I have one of my sister-in-law, um, I don't know if I've mentioned to you, I have a sister-in-law who about 10 years ago was struck with a salivary gland cancer, and a very persistent one. But as a result, she had to have surgery. But then this particular cancer was real slow growing, and so chemotherapy is not effective because it attacks mitotic areas. Well, it was very slow growing, so instead of chemo, she had a lot of head radiation. And that radiation, because it was a salivary gland, but the radiation, the next year she started struggling with bone necrosis in her jaw, which is death of that bone tissue. And she had to have hyperbaric treatment. And she had to go for a few months, a few times a week. She went to this clinic that had a hyperbaric chamber, which is a little room that other people were in, and they had a special device they put around her head so that the air pressure was especially great around her head. But it flooded the blood there. It caused it to be able to saturate more oxygen, and so it helped heal her jaw. And it was very successful with her. It was scary, when her bone was dying, and that was the only way to fix it, is to flush it with oxygen, and this is a way they did it. But it has to do with these saturation points. When you have more pressure around the blood vessel, more can dissolve in it. And that meant the partial pressure of oxygen was greater, and there was a bigger difference then in the partial pressure of oxygen in the blood than in the tissues. And so that meant more oxygen moved at any given moment into the tissues to help them heal. And it's used all the time in the medical setting now. And Cynthia said that people in that room, some of them had these big open wounds. And hers wasn't like that. You couldn't see any damage. Hers was internal. But her jawbone, her mandible, was dying. Mm-hmm. Okay. So, I believe that's it. This is a shorter unit than sometimes. Okay. Well, your test is coming up. So